I now recognize Mr. Hern.
Thank you, Mr. Chairman. Much has been talked about with the supplemental benefits of MA plans. In fact, about 99% of all the MA plans offer at least one supplemental benefit. And over the last several years, the MA program has endured significant funding reductions as a result of the Biden administration policy changes. Unfortunately, due to the past administration's heavy-handed actions towards MA, it is becoming harder for MA plans to offer a wide array of supplemental benefits for our seniors. Dr. Jain, can you explain how this rulemaking in the past 4 years around Medicare Advantage has affected the supplemental benefit offers to seniors? And can you tell us how plans are adjusting or working on this so that they can continue to offer these attractive benefits to seniors?
Sure. I would say there's been two different categories of changes that have been implemented in the program as it relates to rulemaking. So the first has really been risk adjustment and the implementation of the V28 risk model, which effectively has been a revenue haircut to the industry. And when the industry gets less revenue, we're able to offer less benefits. That's how the Medicare bid system actually works. So while V28 definitely addressed some of the types of coding abnormalities that have been discussed at this hearing, it certainly also reflected a cut in revenue to the industry, which translated into less generous benefits last year, will continue this year, and will also continue next year. The second area where CMS made changes was on the star ratings and the methodologies used to actually calculate the cut points for star ratings. And what we've seen is there's been a decline in the number of 4+ star rated plans across the industry. And what that means is that plans are achieving fewer bonus dollars, and as a result, are getting less revenue, and those bonus dollars are actually used to fund supplemental benefits. I would submit that one of the challenges has been that the star rating system has gotten more and more distorted. A single French phone call for Scan Health Plan a couple of years ago would have been, that was a single secret shopper French phone call, was rated in a way that ultimately could have resulted in a $250 million swing in revenue to our plan. And for that reason, we actually had to sue CMS in federal court and actually presided. And so I would just say we have a star rating system that is not necessarily doing what we hoped it would do, which is to reward quality and a robust measures of quality. And I think one of the opportunities you have is to actually grade plans more on a continuum as opposed to have this cliff ratings system, which ultimately results in lower benefits to beneficiaries.
Thank you. A lot has been talked about with MedPAC and some of the conclusions and how they've reached their conclusions. Dr. Miller, you touched on the MedPAC analysis in your testimony, and you recently co-authored an article published by Health Affairs that discusses a recent analysis from MedPAC estimating cost differences between Medicare Advantage and fee-for-service. Can you talk to us about the findings that you wrote about in your article and what we need to know as policymakers as we go forward?
I note that my views are mine and not those of MedPAC's, as evidenced by that article. I would say that we need to answer three questions. One is we need to look at those three populations I mentioned, not just fee-for-service to MA, but people who switch from MA to fee-for-service and the choice that they make when they enter the program. MedPAC only looked at one of those three populations, so we're not getting a 360-degree view of the program. Favorable selection, coding intensity, we've talked many times, and I talked about this at the JEC hearing a few months ago. We need to automate diagnosis coding at the point of care under the purview of a physician. So that way people are completely coded across programs, whether it's fee-for-service or MA. A lot of coding intensity differences are appropriate. Some of them are fraudulent, like what a large plan has potentially done sounds like it's problematic, and there will be and should be oversight of that. Favorable selection, again, we need to look at how this happens in the real world. I don't know what the combine harvester is that a plan is driving down the coast of Florida to pick up all the healthy tennis-playing Medicare beneficiaries. I don't know what the marketing strategy is. I don't know what the plan selection strategy is. I don't know what the benefit design strategy is. I was an FDA product reviewer, and we deconstructed pharmaceutical development programs and then reconstructed what we thought the drug did and didn't do, and then validated that in the real world with pathophysiology of disease. We need to do that for all of the Medicare Advantage to fee-for-service comparisons and have transparency of the data and the statistical coding behind that.
Thank you, Mr. Miller. And Mr. Chairman, I yield back.
Representative Kevin Hern, Republican, Oklahoma, pressed Dr. Sachin Jain, CEO of Senior Care Action Network, SCAN, Health Plans, on how recent policy changes under the Biden administration have affected Medicare Advantage plans and their ability to provide supplemental benefits to seniors. Hern pointed out that nearly all Medicare Advantage plans offer some form of supplemental benefit, but he argued that funding reductions in recent years have made it harder for plans to maintain a wide range of options for older Americans. Dr. Jain explained that two major policy shifts have had a direct impact. The first is the implementation of the V28 risk adjustment model, which he described as a revenue haircut for the industry. While the model was intended to address certain coding issues, it ultimately reduced the revenue that plans rely on to fund extra benefits, leaving seniors with fewer options. This, he said, has already led to less generous benefits in the past year and will continue to do so. The second area of concern involved changes to the Medicare star rating system. Jain noted that fewer plans are now able to achieve 4 stars or higher, which means they receive fewer bonus payments. Those bonuses are crucial because they are reinvested into supplemental benefits for members. He criticized the current star rating methodology, saying it has become increasingly distorted. As an example, he cited a single secret shopper phone call that once threatened to swing $250 million in revenue for his organization, forcing SCAN to sue the Centers for Medicare and Medicaid Services, CMS, in federal court. Jain suggested that grading plans on a continuum, rather than the current cliff system, would provide a fairer and more accurate reflection of quality. Later in the discussion, Dr. Mark Miller addressed broader questions about the Medicare Advantage program and recent analysis by the Medicare Payment Advisory Commission, MedPAC. Miller said the commission's work has been too narrow, focusing only on beneficiaries moving from fee-for-service to Medicare Advantage while ignoring those who switch in the other direction or the choices people make when first enrolling. He also raised the issue of favorable selection and coding intensity, calling for diagnosis coding to be automated at the point of care under physician oversight to ensure fairness between programs. Miller argued that while some coding differences are appropriate, others may be problematic or fraudulent and require oversight. He urged policymakers to demand more transparency in how data is handled and how comparisons between Medicare Advantage and fee-for-service are made. By reconstructing the evidence, much like how the FDA reviews pharmaceutical development, he said policymakers could better understand what is truly happening with costs and care under the two systems.